and proud to call her my colleague and my friend. First things first, greetings from Texas Children's Hospital. A little bit about us. Like most things in Texas, we are big. Our hospital system consists of nearly 1,000 pediatric beds and 4.9 million patient encounters. Over 40 subspecialties are represented, and care is provided by over 2,000 medical professionals. Our Heart Center has had the fortune of being ranked #1 in the U.S. for 8 years in a row and occupies 8 out of 24 floors of our legacy tower. The cardiac ICU includes a 12-bed neonatal CICU, a 24-bed pediatric CICU, a 12-bed heart failure and transplant CICU. In addition, we have a 16-bed mixed acuity adult congenital heart disease center. Our CICU has over 1,500 encounters annually and is staffed by over 30 cardiac intensivists and 60 cardiologists, in addition to our 7 cardiac surgeons. I believe that in order to treat a problem, one must first try to understand it. So what is heart failure in children? This was first described in the 18th century. The following is a description from a textbook in 1899. In children, the heart swells, rapidly enlarges, and the ventricular cavities dilate, and then there follows that contracted leaden consolidation of the bases of the lungs, which is neither simple collapse, nor simple edema, nor simple pneumonia, but probably something of all of these, and which is an excessively dangerous condition because it is an indication of a sorely stricken heart. A sorely stricken heart. So really, what is heart failure? According to the modern definition, it is a clinical syndrome characterized by typical symptoms and signs associated with specific circulatory, neurohormonal, and molecular abnormalities. In the U.S., as much as a third of pediatric cardiac admissions are in patients with heart failure. An older publication reports a mortality of just under 7% and notes that morbidity is rising. I obtained some of our Texas Children's data from the Pediatric Cardiac Critical Care Consortium database, or PC4, just to share with you some of our numbers of admissions. So it looks like from 2019 to 2023, the 2024 data on this slide is not complete, we've admitted anywhere from 400 to 600 patients for medical reasons, and the vast majority of these children are admitted with heart failure. This slide is just to compare these numbers with our numbers of surgical admissions. As you can see, we admit almost as many patients for medical reasons as we do for surgical reasons. These slides illustrate our experience for the time period specified with our outcomes, specifically with medical mortality, failure to rescue, and medical cardiac arrest, all of which seem to follow the national average for participating centers in PC4. Our lengths of stay are slightly higher, as you can see in the bottom right. And I think this is due to some of the novel strategies that we have for supporting patients mechanically that allow support in the hospital environment but do not allow discharge to home, and just the higher complexity of patients that we take care of. As most of you know, the etiology of pediatric heart failure is quite varied. Over 2/3 of patients with heart failure also have congenital heart disease, and cardiomyopathy is the most common cause in structurally normal hearts. These nuances of pediatric heart failure are also not lost on most of you. As I mentioned, the causes of pediatric heart failure are quite diverse. The availability of large randomized controlled trials to inform therapy are quite limited, and as a result, treatment regimens are often extrapolated from adult data. However, we all know that we cannot assume that pediatric patients can be treated the same as adults. In order to organize my thoughts for this talk, I reached for the ISHLT guidelines for the management of pediatric heart failure that were published a decade ago. In this publication, pediatric heart failure was classified into 4 stages. For the purposes of this talk, I will focus on a small extent on stage C and to a larger extent on stage D, the 2 stages that are actually classified as clinical heart failure. So I think these general therapeutic interventions are common to all participating or all practicing pediatric heart centers and include things like nutritional support, dietary alterations, oxygen therapy, immunizations, mental health support, and palliative care. On a broader scale, the goals of medical therapy are as follows: decrease pulmonary wedge pressure, increase cardiac output and end organ perfusion, and ultimately delay disease progression. And to achieve those, these are some of the medications that are commonly used. So returning to patients with stage C heart failure, these are children with structural heart disease with prior or current symptoms of heart failure. The following medications are commonly used in this population and include things like diuretics, anticoagulation, ACE inhibitors, beta blockers, and aldosterone antagonists. However, over the course of my career, I've seen the use of some newer drugs emerge, and these include SGLT2 inhibitors, pulmonary vasodilators, and angiotensin receptor neprilysin inhibitors, or so-called ARNIs. These medications are showing promise in both the adult population, and early studies are showing some encouraging findings in pediatric patients as well. Let's move on now to stage D heart failure. These would be children with advanced heart failure that requires specialized interventions. For patients with low cardiac output or an acute exacerbation of heart failure, milrinone is typically the first choice of inotrope. At our institutions, initiation of milrinone therapy in such patients requires admission in the cardiac ICU. For patients with decompensated heart failure or cardiogenic shock, inotropes with vasopressor properties such as epinephrine, dobutamine, and dopamine should be considered. However, these agents are known to be chronotropic and arrhythmogenic. Alternative options include things like vasopressin and calcium, depending on the overall physiologic milieu. Other ICU therapies such as endotracheal intubation, sedation, and neuromuscular blockade should also be considered. It is, however, notable that there is no demonstrable mortality benefit in adults or children with the use of positive inotropes in chronic heart failure. I wanted to talk briefly about some monitoring devices and practices that we have in our cardiac ICU to follow the overall condition and progression of our patients. And these include things like near-infrared spectroscopy, PICO catheters, SVC lines, flow tracks, Foley catheters, a whole slew of laboratory studies, and imaging options including echo and MRI. For patients who in heart failure that may be experiencing symptoms of deterioration and progression of heart failure, the following flow sheet can be used to help navigate decisions regarding the initiation of mechanical circulatory support. For the purposes of this talk, I'm not going to focus on children with respiratory failure requiring VV ECMO as a bridge to either lung transplantation or clinical recovery. I will instead focus on the cardiac population in the event of acute deterioration without a clear understanding of the etiology. The vast majority of these patients are placed on VA ECMO as a bridge to decision, recovery, or longer-term mechanical therapies. So the indications then for VA ECMO are as listed above. This is by no means a comprehensive list. However, ECMO is a bridge to recovery, decision, durable mechanical support or VAD placement, or heart transplantation or lung transplantation. The following slide illustrates Our Texas Children's experience with the number of ECMO runs from 2018 to 2023. The black line is the total amount of ECMO at our institution, which is over 42,000 hours. The blue line indicates the amount of ECMO support in our heart center, which comprises of nearly 70% of all ECMO runs at our institution. This slide presents our 2023 ECMO data only and shows in the pie chart the indications for ECMO, the vast majority of which is for surgical reasons. And then I've also included our outcomes. So our ECMO outcomes for patients placed on ECMO for surgical reasons is 64%. Our highest survival is for our medical or heart failure patients placed on ECMO with a survival rate of just under 80%. We also deploy ECMO for sepsis patients and have a pretty good survival with that also of just under 70%. These numbers are considerably higher than the average reported in the ELSO database. This slide is one that I've included. It's some unpublished data from Texas Children's Hospital, but just describes our training program for our perfusionists who drive our ECMO program. I want to highlight that a successful ECMO program requires a multidisciplinary approach with a multitude of primary services such as cardiac surgery, perfusion, nursing, nutrition, pharmacy, but also often includes consulting services such as palliative care, neurology, and social work. For select patients who may be deteriorating to the point of needing longer-term mechanical circulatory support, we have a surgical strategy that we have used. I wanted to share some of our experience with PA banding for patients with dilated cardiomyopathy with you. This is something that we consider for any infant with dilated cardiomyopathy who weighs less than 10 kilograms and who is awaiting heart transplantation with an impending need for mechanical circulatory support. Inclusion criteria include the absence of RV failure and a dilated LV to the point of causing pancaking of the right ventricle due to rightward shift of the interventricular septum. It is only undertaken with the possibility of switching to a VAD if hemodynamics do not improve. This graph is from a paper in which 15 American centers participated. There were, including Texas Children's Hospital, 14 patients underwent PA banding with good results. Nearly half of them survived to transplant, and nearly a third of them experienced complete recovery. In patients for whom PA banding served as a bridge to recovery, there were notable echocardiographic improvements with LV end diastolic dimension and LVEF. However, in patients in whom PA banding served as a bridge to transplantation, corresponding improvements in echo parameters were not noted. So in select patients, this could serve as a means to delay the progression of heart failure and provide more time and support while a patient waited for MCS or a heart transplant. Let's talk next about ventricular assist devices. I've listed here the general considerations for placement of such devices in children. We also have experience at Texas Children's Hospital with short-term or temporary VADs. I'd like to share our data with Impella use with you. So Impella VAD devices can be used for a variety of indications that you see listed here. At our institution, we specifically use it as support in the cath lab for high-risk procedures. It is approved for treatment for cardiogenic shock with isolated LV failure. It's a means of LV decompression for patients on ECMO support. It can serve as an important bridge to a decision or heart transplantation and can also provide circulatory support during high-risk surgical procedures. I'm not going to spend too much time on the next two slides. What you can see here, however, that there are different types of Impella devices that provide different amounts of flow and can be used to provide LV support and even RV support. These data are from the Action Collaborative and were shared from data provided by 15 pediatric centers between October 2014 and September 2021. As you can see, the number of Impella implants across the Action Network between this time period has been increasing. Below you can see that the use of Impella is increasing even with the use of other types of short-term VADs. Here is our experience from TCH. The demographic data is not compiled for every patient thus far, but we have, as of November 1st, 2023, successfully supported 51 patients with an Impella VAD. 8% of these patients did not require inotropic support after VAD placement. 60 devices were used, including 2 in the right ventricle. Adult patients were excluded here. And the indications in this table are from the Action Network and serve as a means for you to compare to the data provided from our single center. Impella was successfully used in 70% of cases as a bridge to recovery. And the pie chart here just provides comparison. Our median length of support, ICU and hospital length of stays are also provided above. A total of 104 adverse events were experienced in these 51 patients. The most common adverse events that were reported were hemolysis and renal failure. The graph below is from the Action Network and just serves as a comparison. The use of durable or long-term VADs has increased in the pediatric population, especially with the use of implantable continuous flow VADs, which allow for discharge home in select patients. These VADs account for approximately 40% of pediatric durable VADs and serve as the majority of VAD support in adolescent patients. The potential advantages include the potential advantages of discharging a patient to home with the VAD include many things such as cost savings and the ability to return to school, work, or other pre-heart failure activities that ultimately result in an overall improvement of the quality of life for the patient. The top reasons for ongoing support in adult patients is that the VAD serves as a bridge to recovery or transplant. Approximately 40% of adult patients were transplanted 3 months after VAD placement. And there has been an increasing number of patients with congenital heart disease that are placed on VADs, as well as an increasing number of Berlin implants in this patient population, and in particular in single ventricle patients. However, deaths in Berlin VAD patients happen at a higher rate in those patients with single ventricle physiology or restrictive cardiomyopathy. The journey of a patient who may require VAD placement is a lengthy one, as you can see in this illustration, and includes a multitude of steps, including education, the actual surgery and recovery itself, education following surgery, preparation for discharge, and then close follow-up in the outpatient period as the patient returns to their pre-heart failure activities. Successfully supporting a patient through this lengthy journey requires multiple disciplines with expertise, as you can see here in this diagram. At the core of it, though, remains the patient, their caregivers, and their support system. These data are from Texas Children's and show the number of VAD implants between 2017 and 2024. As you can see, our use of the HeartMate 3 has been increasing in the recent era. The remainder of our VAD data from Texas Children's that I will share with you focuses on implantable continuous flow devices. Between May 2008 and September 2022, 100 such devices were implanted in 98 patients. Of the types of devices, the HeartMate 3 is the one that we have used most commonly in the recent era, although in the overall cohort, the HeartWare 2 is the one that was used most commonly. This next bullet shares our median age, weight, and BSA at the time of implantation. The median duration of VAD support was just under 10 months. However, we have successfully supported a patient for over 12 years. The most common diagnoses in this cohort was cardiomyopathy, with just over a third of patients with congenital heart disease receiving VADs. 80% of these patients were successfully discharged to home, and over half of them were able to return to school or work. One patient even got married and had a child. Overall, in this cohort, 64% of patients were successfully transplanted. There were 14 deaths, of which the most common cause was multi-organ failure. These graphs illustrate our early and late adverse event rate. The TCH data is in blue, and it's being compared to the data reported from the multi-center PDMAX database. And as you can see, with both early and late stage adverse events, our performance has been better than that reported from the PDMAX database. The adverse events reported include bleeding, infection, neurologic dysfunction, and pump thrombosis or device malfunction. Of note is the following postoperative practice at our center that has been in place since 2012. And it is that we observe all VAD patients postoperatively for 3 months before actively listing them for heart transplantation, with very rare exceptions. Our belief is that this allows for physical, functional, and psychosocial recovery, and it's also an opportunity for us to assess for myocardial recovery and avoid premature cardiac transplantation in patients who have significant improvement of their myocardial function. We also consider patients for discharge to home if they meet these criteria outlined below. Patients, once discharged, do have regular and close follow-up with a dedicated team, including VAD coordinators, a heart failure or VAD physician, and a cardiac surgeon. Over half of our patients with implantable VADs have been successfully discharged from the hospital. A detailed discussion of heart transplantation is beyond the scope of this talk, but I just thought I would share this table, which illustrates some common indications for which heart transplantation should be considered or could be considered in patients with advanced heart failure. So here is a simplified decision-making tree for patients with advanced heart failure. Clear as mud, right? So I will conclude my talk here with the following points. There are new drugs and devices on the horizon for the care of patients with advanced heart failure. Short-term therapies such as PA banding and Impella VAD placement may serve as a valuable means to slow the progression of heart failure and in some cases may even mitigate the need for heart transplantation. Mechanical circulatory support is a very resource-heavy endeavor and requires multidisciplinary expertise and large-scale investment. However, the creative implementation of different forms of MCS, such as Berlin cannulas connected to an ECMO circuit, may improve patient viability and overall condition, allow for things like rehabilitation in anticipation of heart transplantation and or eventual recovery. I thank you again for inviting me to speak with you today. It is truly